Okay, class, I did want to go back one more before we move on to benign prostatic hypertrophy, hyperplasia at least. Here's the prostate right here, and again, we spoke of that BPH is common to 40 to 50 in their 50s and 80s, and 80% of men in their 80s. Okay, so it's more common in the older male. The growth constricts the urethra, so you have urinary retention, could even get back up into the kidneys. And one of the common signs of this urinary retention is frequency of urination. Instead of being able to void all the way, then there's a lot of residual urine. So the person, the male, has to keep going to urinate very often, far more often. Because it could be other things that can cause frequent urination, like diabetes. But there are different treatments for this. Some are surgical. Some are, since testosterone is the key, dihydrotestosterone, then one thing is to inhibit the enzyme to produce this dihydroxytestosterone, to inhibit the 5-alpha reductase inhibitors. Alpha-1 receptor antagonist, so this does not constrict. So there are various treatments for that. But I also wanted to mention prostate cancer. Now this one is benign. Prostate cancer is 1 in 6 American men will develop prostate cancer during their life. 1 in 36 will die from it. It's twice as common in the black male than the white male. Risk factors include the fatty diet, genetics, screening test, the digital rectal exam in the male, and a blood test called PSA, prostate-specific antigen, which is produced by the prostate, a certain level. Once that PSA reaches a certain level, generally about a 2.5 micrograms, then it could be show that there may be something going on. Of course, the PSA could be elevated for prostatitis, which is inflammation of the prostate, and sometimes benign prostatic hyperplasia. So there are various things. Wanted to just point out that testicular cancer is another cancer, but it's more common in the younger male, whereas prostate is more common in the older male, as we mentioned earlier. Now, we now are looking at this. We want to get into the male sexual response. All right. Now, you may recall that the sexual response is both male and female. These are the periods. You have excitation, both female and male. Then you have a plateau effect that I have brought up earlier. Then you have the orgasm. Then you have remission, which basically brings you back to where you are before, the person, and so forth. And so these are the steps that you would have, basically. And so erection, and so the steps again would be excitation, plateau, orgasm, recovery, I won't call it remission, but recovery, and those are basically the steps. Okay, erection in the male, which is the enlargement and stiffening of the penis, is due to trapping blood, to be very honest. And the corpora cavernosa, two corpora cavernosa, the corpora spongiosum. The corpora spongiosum is that tissue around the urethra, but the cavernosum, if you recall, are two bodies that you have at the dorsum of the penis. Two erectile bodies at the dorsum of the penis there. Let's see if I can find that. Here would be this. So I'm going to blow this up a little bit. right here, these would be the corpora cavernosum and spongiosum. They have blood vessels and open spaces here. This is the dorsal vein. Now, deep dorsal vein. So what happens is that there's engorgement of blood within the corpora cavernosum. The parasympathetic nervous system causes the vasodilation of the arterioles leaking in the corpora cavernosum to bring engorgement of blood into that area. Okay, let's go here. Here again, corpus cavernosum, spongiosum. Okay. Nitric oxide is a key entity. Nitric oxide will come in, and this nitric oxide is going to act as a neurotransmitter. In this case, it's going to come from the parasympathetic nervous system, which normally secretes acetylcholine, but in this area, there's some nitric oxide secreted, and also from the endothelial cells in the corpora cavernosum. In that particular case, parasympathetic stimulation of acetylcholine will cause release of nitric oxide from the endothelial cells in the blood vessels of the corpora cavernosum. What the nitric oxide does is to activate guanylate cyclase, which is an enzyme that will convert GTP to cyclic GMP. GTP, guanine triphosphate, to cyclic guanine monophosphate. This acts as a secondary messenger. The secondary messenger then closes calcium channels. Now remember, blood vessel muscle is smooth, so it needs calcium. By closing, and it comes from the outside primarily, so the calcium channels close, which decreases cytoplasmic calcium. As you know, what that does is contraction cannot occur. That relaxes that and causes vasodilation. The vasodilation then brings in engorgement of the blood vessels in this, and since there's a tight covering around here, the skin here, you could say, skin of this, then what will happen, and the tunica albuginea, when all of this engorges, it compresses the veins. It compresses the veins. Once the veins are compressed, you have blood coming in, but what? You can't get the blood out. So the penis becomes erect. So here again is a picture. Some of the parasympathetic axon terminals are releasing nitric oxide. Some of them are releasing acetylcholine, but those that release acetylcholine still cause the vascular endothelial cells to release nitric oxide. The nitric oxide goes into here, the vascular muscle cell. When that goes in, it causes GTP to become cyclic GMP, secondary messenger. That closes the calcium channels. Calcium cannot come in from the outside, and the smooth muscle relaxes, and you get vascular engorgement. So the erection is controlled by the hypothalamus, this is in the brain, and the sacral region of the spinal cord. Hypothalamus, sacral region of the spinal cord. Because it's controlled by the hypothalamus, it also has conscious activity because the cortex of the brain could stimulate the hypothalamus. But you don't have to have that. Just stimulation to the penis itself could cause this action, so it doesn't have to come from the brain. Emission and ejaculation. The semen now is going to, these sperm, shall I say, is going to move from the epididymis. From the epididymis, it's going to enter, if you recall, into the vas deferens. Once it enters into the vas deferens, then the seminal vesicle will connect with the vas deferens at the ampulla of the vas deferens. then that forms the ejaculatory duct. The seminal vesicles are sending out 70% of the fluid into the semen, and now rhythmic action would cause ejaculation of this. Ejaculation, however, is a sympathetic activity. That's the sympathetic. So the parasympathetic causes the erection, and the sympathetic causes the ejaculation. Let me say it again. The parasympathetic causes the erection, and the sympathetic causes the ejaculation that would occur. So in erectile dysfunction, the gentleman can get an erection. Then there are many reasons for that. Some could be poor blood supply due to atherosclerosis, heart disease, which could cause this. Depression can cause it too, because remember, it is a conscious activity. But for those, a possible treatment. Now, if there's a lot of vascular disruption in the arteries coming off the aorta, then none of this will work to any great extent. But one of the Viagra and Cialis, two most common, what they do is to inhibit phosphodiesterase. Okay, so let me go back. Go back here. Phosphodiesterase breaks down cyclic GMP. That's the enzyme to break down cyclic GMP. If cyclic GMP is broken down, then that means the calcium channels will open, right, and allow calcium and cause vasoconstriction. So if you could block that, so coming back, Cialis and Viagra are competitive enzyme inhibitors of phosphodiesterase, which then would disallow cyclic AMP to be broken down and therefore promote the erection. A sperm count, generally the person will secrete about 1.5 to 5 mils of sperm. The sperm count is less than 20 million per milliliter of semen is called oligospermia, and the male is less fertile. It can be caused by heat, drugs, anabolic steroids, and things of this nature. Here's the semen analysis that you can look at. In an infertility workup of a female, 50% of the time, and in some cases, some say more, is due to the male and not the female. So it behooves a physician, gynecologist, to do the semen analysis on the male. Either they do it or they send them to another doctor to be sure, because the analysis of the female in infertility is far more costly and invasive than that on the male. All the male has to do is give some semen, bottom line. So male fertility, one way on contraception is to do the vasectomy, which would be to cut the vas deferens. And it does not affect testosterone production. It would be almost like a tubal ligation in the female. Some males develop anti-sperm antibodies. Other methods, condoms, suppressing this. So research on this, but there are too many side effects. This is a gel that you can inject that might close off the vas deferens. That again is very experimental. Okay. And so this gel here. Here's the vasectomy picture there. Cutting that vas deferens. Okay. That actually closes out everything for the male.